emergency. Okay. This is what delirium is. Okay? So, this happens suddenly, acute onset, fluctuating course. So, for example, you have an 80-year-old patient, an 88-year-old female, okay, who's okay, she's alert and oriented, she's fine, she's focused, she knows where she is, and all of a sudden, she's confused, okay, acute onset. All of a sudden, she has reduced ability to direct, focus, shift, and sustain attention, okay, disorganized thinking, disturbance of consciousness, okay, she's agitated, she's delusional, she's, what are you guys thinking? If you're your 80-year-old patient, what do you think she's going through right now? So we know she's delirious. Delirium suddenly happened. What do you think? What do you think is going on? An 80-year-old patient suddenly is confused. Guys, infection, UTI. That's delirium. Okay, it suddenly happens. Our delirium tremens suddenly happens. So with delirium, this is reversible. You treat the underlying issue, you can go back to your regular self. Okay? So this happens suddenly. This doesn't happen gradually, this is sudden. Okay? Makes sense, right? Now, the whole point, so risk for injury, we have to keep them safe, acute confusion. Okay? So the whole point, the outcome, patient will return to a pre-morbid level of functioning. So this is why this is a medical emergency. If you don't treat the underlying cause, it becomes a medical emergency. It can get worse. If you don't treat your infection, it can, this infection can travel to your kidneys, and then that produces a whole other type of problem. So patient will be safe, free from injury while in the hospital or wherever they are. Patient will be oriented to time, place, and person. Patient will be free from falls and injury. So then you fix the underlying cause, patient will return to pre-morbid level of function. That's the goal, and it's doable, and it always is. Okay? Implementation. So what the heck am I gonna do? Right? I've kind of repeated myself here, but that's okay. So prevent physical harm because they're confused, possibly anxious, irritable, aggressive, or fluid and electrolyte imbalance, right? Or replenish everything they're missing. Perform comprehensive nursing assessment to figure out why they're feeling delirious. Assist with proper health management. Use supportive measures to relieve the stress. And then evaluate, right? So they're confused all of a sudden. You're going to get that urinalysis. You're going to send it to the lab. It's going to come back positive for all this protein. You're going to start them on amoxicillin, doxynamox, right? You guys know that. And then they're going to get treated. The infection's going to go away, right? And then they go back to normal. Okay? So that's delirium. It's reversible. Now, moving on to dementia. So dementia is progressive deterioration of cognitive functioning and global impairment of intellect. So there's no change in your consciousness suddenly. Okay, with delirium there is. With this, it's very progressive. They're normal for a very long time when it comes to their orientation. So difficulty with memory, problem solving, and complex attention. So clinical picture. So this is oftentimes dementia is due to what? We're going to touch on Alzheimer's, due to substances, Parkinson's and Huntington's, right? Maybe a prior disease, HIV infection. So dementia is due to a bunch of these disorders. Okay, a lot of the meds we're going to talk about, we also utilize for a lot of the meds we talk about for Alzheimer's, we use for Parkinson's and Huntington's, and we'll discuss why. Okay, so we're going to talk about Alzheimer's. Okay, so gradual irreversible dementia resulting in memory problems, judgment issues, and changes in personality. Let's dive into it. So there are 3 stages of Alzheimer's, okay? There are 3 stages of Alzheimer's that your ATI touches on. We're going to go over that shortly. So my general assessment of someone who has Alzheimer's, and my patients exhibit this all the freaking time, okay? First defense mechanism, denial. Both decline. This usually happens in the first stage, okay? Both client and family refuse to believe that changes have occurred, such as loss of memory, are taking place. So the first stage we're going to go over, they start to become forgetful. They will misplace things, and although they notice and realize this is happening, both the patient and the family, they will deny it. Okay. Around stage 2, the patient experiences confabulation and preservation. Okay. So confabulation, they make up stories to fill in memory gaps, okay, to prevent admitting that he or she does not remember things. So by stage 2, there are chunks of memories that they don't really remember, and so they will make stuff up. Okay, they will make stuff up to fill in those gaps. Okay, and again, they will be in denial that something, that they're experiencing all this memory loss. And then preservation, repetition of words, gestures to avoid answering questions. Remember echolalia and echopraxia? Same thing happens here. And sundowning. This is just unexplainable. When I visit my patients who are in nursing homes who have Alzheimer's, I just don't understand how they get all the strength. They're like cute little 80-year-old grandmas who are in like stage 3 Alzheimer's, and then they become so strong. And they've scratched me so many times as I've been taking their vital signs. Very sad. It is very sad. It's very, very sad. And I just don't understand how sundowning, how I can't explain it. It's just these cute little 80-year-old grannies for the sweetest things in the morning until the afternoon, and then the sun sets, literally, they start to get very aggressive. Sundown. I've been scratched, my hair has been pulled before. It's all good though. It's all good. And then there are lots of screening tools we utilize. I don't touch on them, but there's functional dementia scale, MMSC, functional assessment tool. I don't touch on this, but again, go over them so your eye can know what it's about. Sorry, guys. Symptoms of Alzheimer's. So memory impairment, okay. Disturbances of executive functioning, aphasia, inability to form words in context to communicate, like they just will not be able to communicate, correlate like a sentence or correlate their thought to you. Apraxia, ability to brush their own hair. Well, ability to basically care for themselves goes out the window, okay? Agnosia. You guys know what agnosia is? Any guesses? No? Basically forgetting what each item is for, like they're not going to know that this is a cup, that this is a water bottle, that this is a hairbrush, that this is a pen. Yeah, they're not going to know that. Yeah. Right? So all of this happens within the last stage, severe stage. Sad stuff. Really know this. The 3 A's, you should know it. Now, your ATI book talks about 3 stages, and that's the stages I'm going to talk about. So mild, forgetful, short-term memory loss, mild cognitive impairment. So this is where they start to misplace items, they can concentrate, but they can still care for themselves. So this is where they're in denial. They're in denial here. Their family can also deny it, but those who don't, so the ones next to them will notice this change is occurring. Okay? So they can still care for themselves. It's totally fine. Stage 2 is moderate Alzheimer's, right? So disorientation, agitation, wandering around. They can't, difficulty planning, organizing, personality, behavior changes. This is one time I was admitting a hospice patient, and her history was she left the stove on, she opened the door and she left, and her family couldn't find her for like 2 hours. For like 2 freaking hours. Personality changes, behavior changes. This is where you see drastic change. Stage 3, severe. At this point, you're caring for them 24/7. They are bedridden. Aphasia, agnosia, apraxia all come into play. Dysphagia. You have to help feed them because they forget to chew. They will choke on their food. Literally, they will forget to eat and they will forget that they need to chew. Assistance needed with all ADLs because death can occur in this stage due to infection or choking. You're caring for them 24/7 at this point. Okay? Your book has broken this down into 7 stages, which I find to be unnecessary. Literally, stage 1 to 3 of your book is stage 1 in ATI. Okay? Stage 4, 5 is stage 2 in ATI, and then 6, 7 is stage 3. It's literally the same. I don't need you guys to go through the book. Focus on the ATI stages. Okay? I'm not going to even focus on that. Okay, so this made my life easier. Okay, so when I'm working on the Jerry Psych unit, I make sure all of this is in play. Okay, provide safe environment. Obviously, they're confused, they're disoriented. You want to make sure that they're close to the nurse's station. Door is open. Maybe they're on a one-to-one. Bed alarms working and on. You want to make sure you prevent them from wandering around, from falling. Okay, so you got to always reorient them consistently because they're disoriented. So the clock and calendar is in front of them, literally right in front of them, so they can see what day it is, so they could see what time it is. Okay, all of that has to be visible to them. Reorient the patient as needed. As needed. If it means, sometimes what happens is they'll pack their bags and like, I want to go home. Like, I'm going home. I'm going home. You gotta redirect them. It's like, oh, I see you're all dressed up. You want to go? Let's go back to your room, or let's go to the day room and watch some TV. Reorient them. Okay, reorient them. Sometimes, not sometimes, but a lot of the times they wander around and they go to, like, they'll walk into the nurse's station. They'll walk into someone else's room. If that happens, you take them by the hand and you lead them back to their room or where they have to go. Okay. Maintain consistency with caregivers. Yeah, be very consistent. If you're working 3 days in a row, make sure you're caring for them 3 days in a row. Does that make sense? So that way it's less anxious, less stimuli. They're familiar, hopefully. Calm voice, short sentences. Don't scream at them. Don't yell at them. Don't utilize long sentences. They don't understand. It's just they can't concentrate. Limit choices. Limit choices. Straight to the point. Okay? Home safety. Sorry, guys. Okay, this is what I check for every time I walk into their homes if I'm visiting my home care patients. I make sure all of this is perfect. So, no scatter rugs because you're preventing falls. They can slip on this. They can trip on this. Remove clutter. No one cares about cute little stuff. Okay? Get rid of it. Get rid of it. Baby-proof the place. Get it. Trash. Okay? Minimal. Install door locks. Away and out of sight and out of reach so they can't wander away. So they can open the door and just walk away. Lock away cleaning supplies. Remember? Agnosia? They don't know what anything is at this point. So they can drink cleaning supplies. And they can eat whatever they're not supposed to. Lock it away. Provide good lighting. Remember, they're wandering around. So good lighting with steps, with stickers on the step edges. Okay, so first of all, they should be on the first floor because we want to prevent falls. But if they're wandering around, they might take the stairs upstairs or downstairs. Make sure that there's colored tape where they can see where they're going. Okay, install handrails in the bathroom so they don't fall. Right, place mattress on the floor and secure electrical cords to baseboards. So home safety. All of this is to prevent falls and keep them safe. Okay. Meds. Okay. Pharmacological interventions. So, donepezil. So your Aricept, Exelon, and Namenda is what I'm going to focus on. Make sure you recognize that Cognex and Razidine is also for Alzheimer's. However, I promise you, Aricept, Exelon, and Namenda will probably be on the Proctored also, and on my exam. Okay, so these are all to treat Alzheimer's. Now, here's the deal: they do not cure Alzheimer's. There is no cure for Alzheimer's, and you're gonna educate the family on this. You know, your loved one is on Namenda. So are they gonna get better? No, they're not. This is just going to help them stay independent for a longer period of time. They'll be able to perform their activities of daily living. They'll be able to brush their hair, by themselves for a longer time. So it helps them stay a little more independent longer. But there is no freaking cure. Okay. Exelon patch, rivastigmine. Okay, so this is valid for a day. Okay, you place this patch on a clean, dry area for 24 hours. Okay, works the same way. It's the same thing. It's not a cure. It helps. It's the dosage of the Alzheimer's med that you need to help you stay independent for a longer period of time. Okay. Aricept, this is the one I commonly give, even more common than Namenda. Right? Slows cognitive deterioration, improves the ability to perform ADLs. All of them are like that. And you give this once at bedtime. Once at bedtime. It kind of makes you a little bit dizzy, kind of makes you sleep. So you give it at bedtime. So, safety risk, right? Also, so you want to make sure you educate them on that if they are on this drug, if they're on Aricept, to not take it with ibuprofen or any over-the-counter med. You should avoid taking over-the-counter ibuprofen for pain. GI ulcers. There's a risk for GI ulcers. I hope you guys are writing this down. I forgot to write it in the slide. Okay. Make sense, guys? Okay. So we obviously treat it's very behavioral. Alzheimer's. So we do give them sleep meds. Melatonin is something we can utilize 1 to 2 hours before bedtime. Trazodone is something we can give. Okay. For sundowning, right? It's agitation, psychosis. Quetiapine, Seroquel. We can give it to them. 12.5 milligrams is a very low dose. Oftentimes it's not this low, but we can give it to them. Right? We can also give it for sleep. Parkinson's symptoms. So Parkinson's patients, they get these meds. They get donepezil, they get Exelon, because with Parkinson's, our goal is to help them stay more independent with their ADLs for a longer period of time. Same thing. And of course, we use some SSRIs if they have depression, right? That's kind of self-explanatory. Okay. And this is a little box that I made. I'm thinking select all that apply. Okay. Dementia versus delirium. Dementia is gradual, right? Chronic, progressive, and irreversible. There's no cure, usually due to an underlying neurodegenerative disorder, right? Alzheimer's, Parkinson's, Huntington. Level of consciousness is unchanged until you reach that severe level. Normal behavior until advanced stage. Delirium is sudden and reversible. You fix underlying cause, you can go back to your normal stage. Okay? Alterations in level of consciousness usually present in the moment that they're experiencing the delirium. Disturbed behavior, easily distracted, sleep-wake disturbances, hallucinations, all that stuff. Does this make sense? It's a really good way to study these two.